Everyone. Today, I, Dr. Riya, will be presenting my seminar on the ethical guidelines in psychiatry. On the ethical guidelines in psychiatry and medicine in India, critical analysis. I will be covering the following topics in my seminar. I've tried to keep all the slides very simple for everyone to understand easily. So, starting with what is ethics? It's basically about figuring out what's right and wrong in how we act. In medicine, it is about making moral decision when caring for people. It's important as it guides us to do good, avoid harm, and respect our patients. Why ethics is necessary in psychiatry is, first of all, it's a very personal field. We deal with people's deepest thoughts, feelings, and vulnerability. This makes trust super important to us. Patients can be vulnerable. Mental illness can sometimes make it hard for patients to speak up for themselves, understand things clearly, or make decisions. For example, a patient with severe psychosis might believe their food is poison, making it difficult for them to agree to eat. Decision making in psychiatry can be tricky. For example, a patient's illness might affect their ability to make clear decisions, which challenges their autonomy, that is, their right to choose. Patient in manic episode might want to spend all of their money or make impulsive decisions. That is not good for them. Power imbalance. As doctors, we have a lot of knowledge and influence. We must use this power wisely and never exploit it. A patient might look up to you and agree to anything you suggest, even if they don't fully understand or agree to it. New discoveries and treatments. Science and society is always changing, bringing new ethical questions. There is a lot of stigma that is associated with psychiatry. Ethical practice means fighting against this stigma and treating all patients with respect. Ensuring patients with mental illness receive the same quality of care as those with a physical illness. Coming to history of ethics in psychiatry, what were the earlier ideas? Ethics in medicine goes back to about thousands of years. As we all know, we all take the Hippocratic Oath, which is from ancient Greece. It's a famous pledge for doctors to do good and avoid harm. The main thing is first, do no harm. This is still a core principle today. In the late 1800s, doctors like Thomas Percival started writing down more formal rules for how doctors should behave. What were the big changes in ethics in psychiatry after the World War II? Basically, it is surrounding the unethical research which was there after World War II. Example is the Tuskegee syphilis study. It is in this study, African American men with syphilis were observed but not treated for decades, even when the effective treatment became available. The other example that I would like to state here is the Willbrook State School study. Children with intellectual disabilities were intentionally infected with hepatitis to study the disease. These terrible mistakes led to a strong push for clear ethical rules to protect the patients. What are the modern foundations of ethics? Because of the past mistakes, we now have clear rules for research and patients' rights. The two main reports that or the two main principles that we now follow are based on the Belmont report in 1979. It is a US report that laid down three core ethical principles for research involving humans, that is respect for persons, beneficence, and justice. The principles of biomedical ethics, which was given by Bocham and Childress in 1979, became the super influential book as it defined the big four principles that we use today. Main ethical principles, that's the big four, include autonomy, which is the patient's choice, beneficence, doing good, non-maleficence, do no harm, and justice, which is fairness. Let's understand one by one very easily. Autonomy is the patient's choice. It means respecting the patient's right to make their own decisions about their health and treatment. It's about self-determination. It is important, as patients are individuals with their own values and goals. We should respect their right to choose even if we don't fully agree with their choice. Patients should be active partners in their care and not just passive recipients. Example, a patient with mild anxiety prefers to try medication and exercise before the medication. If they understand the pros and cons, you should respect their choice. For a patient with chronic depression, after understanding all options, decide they do not want ECT. If they have the capacity to make this decision, we as psychiatrists must respect it. What's the challenge in autonomy is if it's impaired. What if a patient's illness makes it hard for them to make clear decisions? For example, a patient experiencing severe paranoia refuses food, believing it's poisonous. Their autonomy is impaired by their illness. Then we might have to intervene for their well-being. Now, coming to the second principle, that is beneficence, doing good. Means always trying to help the patient and do what's best for them. It's about maximizing benefits and promoting their well-being. Our goal is to improve the patient's health, reduce their sufferings, and enhance the quality of life. It isn't just about wishing them well. It's about actively intervening to help. For example, prescribing an antidepressant that we believe will significantly improve the patient mood and functioning based on evidence and our clinical judgment. Suggesting a patient with severe social anxiety to try exposure therapy, even if it's uncomfortable at first, because we believe it will lead to long-term improvement. The challenge here is sometimes what we think is best for the patient might conflict with what they want. For example, we believe that individual hospitalization is necessary for a patient who is actively suicidal, even though they strongly resist it. Here, beneficence, that is saving their life might temporarily override the autonomy. Expression of the principle of beneficence is called paternalism. The use of psychiatrist judgment about the best course of action for the patient or research subject. Paternalism can be of two types, weak and strong. In weak paternalism is basically acting beneficiently when the patient's impaired faculties prevent an autonomous choice. And strong paternalism is acting beneficiently despite the patient's active autonomy, intact autonomy. Coming to non-maleficence, that is, do no harm. It means making sure you don't intentionally hurt the patient. It's the famous first do no harm principle. It's important as patients trust us not to cause them injury or suffering. It just does not include physical harm, it includes psychological, emotional, and social harm as well. Example, carefully monitoring for side effects of medications such as weight gain, sexual dysfunction, cardiac issues, and adjusting the dose or switching the medications to prevent harm. Avoiding techniques in therapy that could re traumatize a patient or worsen their condition. The challenge here is almost every treatment has some risks. Non-maleficence means weighing this risk against the potential benefits. Example, ECT has risks like memory loss, confusion, but for severe life-threatening depression, the benefit of rapid improvement might outweigh the risk. You must minimize that harm first. Justice, that's fairness. Treating all patients fairly and ensuring everyone has a fair chance at getting healthcare. It's about equitable distribution of resources. Your personal biases about race, gender, religion, socioeconomic status should never affect how we treat patients. It also means advocating for fair access to mental health services for everyone in society. Example is ensuring that a patient who is homeless receives the same respectful and thorough evaluation as a patient with private insurance. Advocating for more government funding for community mental health centers so that more people can access care, especially in underserved areas. The challenge is the limited resources that we have. What happens when there aren't enough resources for everyone? Example, if there is a long waiting list for a specialized therapy, how do we fairly decide who gets it first? Here, the ethical questions can arise. We have some other ethical principles for persons. Example, respect for person. It means treating everyone with respect, every patient with dignity, valuing them as unique individuals and recognizing their inherent worth. It's more than just politeness. means truly seeing and acknowledging their humanity even when they are severely ill. Example, speaking directly to a patient with schizophrenia even when they are withdrawn rather than only speaking to the family members. Respect for the law means following all rules, regulations, and laws related to patient care and medical practice. Legal versus ethical. While ethics guides right and wrong, laws are must-do rules. They often overlap. Example, understanding and following the MHA in India regarding patients' rights, involuntary admissions, and advanced directives. Coming to compassion and fidelity, compassion is showing empathy, kindness, understanding for your patient's suffering. It's about connecting with their pain. Example, taking extra time to listen to a patient who is crying and expressing deep sadness rather than rushing through the appointment. Fidelity is trustworthiness, being loyal, reliable, and faithful to your patients, keeping your promises. For example, if you tell a patient you will call their family or send a referral, you follow through that promise. Integrity and veracity. Integrity is being honest and having strong moral principles, doing the right thing even when no one is watching. Example is accurately documenting patient information even if it shows a mistake you made. Veracity, that is truthfulness, always telling the truth to your patients in an understandable way. Example, explaining the potential side effects of a medicine even if they are rare or might make the patient hesitant to take it. Don't hide this information. Coming to the big ethical challenges, that is informed consent and capacity. What is it? It's the cornerstone of respecting patient autonomy. It's not just a signature, it's a process. It means a patient agrees to treatment because they understand it, they are not forced, and they can make a clear decision. First is information sharing, that is telling your patient everything. Our role is that we must be clear, balanced, and provide complete information. It includes what is the illness, what is the treatment needed, what are the risks and benefits of the treatment, what are the other treatment options, and what might happen if they don't get treated. For example, for an antidepressant, we should explain common side effects like nausea, sleep changes, but serious ones like suicidal ideation risk in young adults, how long does it take to work, and the psychotherapy as an alternative must be explained. Next is the decisional capacity. We basically means that can they understand what we are trying to tell them? The patient's mental ability to understand the information you give them and think through the decision. It's not competence. Competence is a legal term decided by court. Capacity is a clinical judgment that we make. What are the challenges? Challenges include severe psychosis, dementia and cognitive impairment, and fluctuating capacity, capacity that happens in delirium or acute mania. Example, a patient with severe OCD refuses medications, stating that all aliens will control my thoughts. This suggests impaired capacity to understand the treatment's purpose. Next is voluntarism. That is, are they free to choose? The patient must be free from coercion or undue influence. No one should be forcing or pressurizing them. It's important as a decision made under due stress isn't truly autonomous. What could be the sources of pressure? That could include family. If you don't take this medication, we will disown you. Institutions, if you don't agree to treatment, you can't leave the hospital. Or doctors subtly saying, using over persuasive language or making patients feel guilty. Ensuring a patient isn't agreeing to treatment just because their family is threatening to cut off financial support. Next is confidentiality and its limit. Confidentiality basically means keeping patients' information private is absolutely crucial. It builds trust, which is the foundation of the doctor-patient relationship. If the trust is broken, the patients won't share important details, making it harder to help them. How keep things private is guard the records. Protect psychiatric records with extreme care. It includes paper charts and files. Patient authorization. Only share information if the patient gives you explicit permission, usually in writing. need to know. If you must share information with another doctor involved in the care, only share what's absolutely necessary. Teaching or research. When discussing cases for teaching or research, always remove any details that could identify the patient. Social media, never discuss patients or their details on any social media account. There are specific situations where the duty to protect others or the law overrides confidentiality. The first is the duty to warn or protect, that is called as Tarasov's duty. If a patient threatens serious physical harm to a specific or an identifiable person, example, a patient says, I'm going to kill my boss when I get out of here. You have a duty to warn the boss or the police. What is mandatory reporting when confidentiality can be broken is child abuse. If we suspect a child is being abused or neglected, elder abuse, if we suspect elderly person is being abused or neglected, and in case of court orders, if a judge legally orders you to release information. In emergency situations, if a patient is in immediate danger to themselves or others, and intervention is needed, example in involuntary hospitalization. Privilege refers to the patient's right to prevent disclosure of information from the treatment in judicial hearings as well. A subpoena is not an automatic license to release the entire record. A psychiatrist can petition the judge for an in-camera or a private review to define what precise information must disclose. Coming to professional boundaries, these are the invisible lines that keep the doctor-patient relationship professional, safe, and focused on the patient's health. They protect both the patient and the doctor to prevent exploitation of the patient, maintain trust, and ensure the doctor's objectivity. Professional boundaries are important. ठीक है. Sorry. Crossing the lines or the violations. These are behaviors that are clearly harmful, unethical, and often illegal. They exploit the patients and misuse of the doctor's power. Let's state some examples of violations. For example, having a sexual relationship. Having any romantic or sexual contact with a current or recent patient is absolutely prohibited. Making business deals, asking a patient to invest in your business, lending you money, provide services for your personal gain. Exploitation, using patients' information for personal benefit. Excessive gifts, accepting very expensive gifts from a patient, which can create a feeling of obligation on the doctor's part. Stepping close to the line, that is called as crossing. These are behaviors that deviate from the usual professional practice but might be intended to help the patient. They require careful thought. Examples of crossing, that is, can be okay if done carefully and for the benefit of the patient, includes brief self-disclosure. Briefly sharing a minor personal detail if it helps the patient feel understood or builds rapport. Example, I also find traffic frustrating. Accepting small gifts, accepting a small symbolic gift, especially if it's culturally significant, like a small homemade craft. Attending a patient's event, attending a patient's public event, example a concert when they are performing, if it's clinically appropriate and doesn't blur the lines. These are rare exceptions. Always we should ask, is this truly for the patient's benefit and does it risk blurring lines? Having two roles, that is dual agencies. When a psychiatrist has more than one job or responsibility, that might create conflicting duties. Our duties in one role might clash with our duties in the other, leading to divided loyalties. Example, when we are a clinician and an administrator, you are a patient's therapist, but also the hospital's administrator who decides if their insurance will cover extended stay. Our duty to the patient's care might conflict with the hospital's financial goals. And as a forensic psychiatrist, we evaluate a patient for court. Example, their competency to stand a trial, but then they ask you to be a therapist. Your role in court is to be objective, not to advocate for the patient. Conflict of interest. When outside interests, especially financial ones, might unconsciously influence your medical decisions, like pharmaceutical company influence. A drug company sponsors your research, pays you to speak at conferences, or gives you gifts. This can subtly influence which medication we prescribe, even if we don't realize it. Our job is to be smart and critical, always evaluate research and drug information independently. Our primary loyalty is always to the patient and not to the pharmaceutical company. Coming to kids and teenagers, they are special as children and adolescents are still developing physically, emotionally, and cognitively. They need extra protection and different ethical consideration. Vulnerability, they are often dependent on adults and may not fully grasp complex medical information. Consent versus consent. Consent, it's legal. It is given by parents or legal guardians for a minor's treatment. They have the legal right to make decisions for their child. Assent is the child's agreement. Child's agreement to participate in treatment or research. As children mature, their assent becomes more ethically important. Example, a 10-year-old might not legally consent, but you should explain their treatment in simple terms and get their assent or agreement, respecting their developing autonomy. Coming to a dilemma, what if a teenager refuses treatment that their parents and doctors think they desperately need? A 16-year-old with severe anorexia refuses to eat, and their parents want them hospitalized. You need to balance the teen's wishes with their immediate medical danger and parental responsibility. Confidentiality with minors is a tricky balance. It's hard to decide what information to share with parents and what to keep private for the child. Our goal is to encourage open communication while protecting the child's trust. The general rule includes inform the child what you will share with the parents. I'll tell your parents that you're feeling sad, but I will not tell the specific details about your diary. Confidentiality can be broken if the child is in danger to themselves or others. Example, a 14-year-old reveals that they are being physically abused. We have a duty to report it. Early treatment for future problems. The question here comes, should we treat in the prodromal phase of psychosis? Ethical concerns here include over medication and the long-term side effects along with effects and the stigma, which labels the child as risk for serious illness. Example, prescribing antipsychotics to a teenager showing very mild non-specific symptoms that might indicate a future risk of schizophrenia. End of life ethics, these are tough choices. These involve decisions about stopping treatment for patients with terminal illnesses or controversial topics like physician assisted suicide. Psychiatrist's role is that we often assess the patient's mental state, especially if depression or hopelessness is affecting their decisions. Through checking capacities, it's vital to check if a dying patient can still make clear decisions about care. Patients near the end of life can be confused, depressed, or feel hopeless, which can affect their capacity. We should look for a consistent sense of self, understanding of their condition, and the ability to reason rather than just perform a score on a mental examination. Example, a patient with terminal cancer and severe depression says they want to stop all food and water. We need to assess if this is a clear, informed choice based on their values or a symptom of their depression that needs to be treated. Stopping the treatment. It's generally ethical and legally acceptable to stop treatments that are no longer helping or a cause of more suffering than benefit. Here comes the ordinary versus the extraordinary measures. Ordinary is basic care like pain relief and hydration. Extraordinary is treatment that are burdensome, expensive, or offer little hope of benefit. Example, is a feeding tube ordinary care for someone who can no longer swallow, or an extraordinary measure that may be simply prolonging the suffering. Special situations include violence and legal issues. Dealing with violence. When we evaluate someone who has been violent or committed a crime, our opinion can have a huge consequence for their life and freedom. It is a very serious responsibility. Our role is to understand the biopsychosocial factors that might contribute to violent behavior and to assess the risk accurately. Coming to insanity defense. Did the person's mental illness prevent them from knowing right and wrong when they committed a crime? The psychiatrist must provide an expert opinion and competency. It is the person's mental capacity to understand the court process and helping their lawyer. Example, competency to stand a trial, competency to waive counsel, competency to be executed. We also have neurosciences like brain scan. However, this is still in the evolving area. Protecting others. Our duty is to protect. Sometimes our ethical and legal duties to protect community from a dangerous person overrides confidentiality. Example is of the Tarasov's case. A famous court established that psychiatrists have a duty to warn in identify third parties if their patient expresses a serious threat of harm against them. Example, if a patient tells you that they plan to seriously injure a specific person, you might have to warn that person or the authority, even if it breaks the confidentiality. Coming to the new ethical challenges, this includes money and healthcare, that is resource allocation. The problem is that healthcare resources are limited. Then how do we fairly distribute them? Insurance companies or government programs try to limit costs, which can sometimes affect the quality or amount of care a patient receives. Our role is to advocate for our patients to get the care they needed, even within the system limitations, and work to ensure justice and access to care. Talking to the media, should psychiatrists give opinion about public figures they haven't personally examined? Here comes the cold water rule, an ethical guideline from the American Psychiatric Association that discourages this. It is unethical to diagnose or comment on someone's mental state without a proper examination. Ongoing research ethics, we still need to be very careful about getting true informed consent from vulnerable people in research studies. Example, ensuring patients with severe mental illness do they fully understand that they are research study and can withdraw at any time. Involuntary treatment and the MHA. When a patient is admitted to a hospital or given treatment without consent, this is what is called as involuntary treatment. It is a major ethical and legal challenge. It balances the patient right to autonomy with the need to protect them or others. Mental health care of 2017 in India. This act provides the legal framework for involuntary admission and treatment in India. It aims to protect patients' rights while allowing necessary interventions. Criteria for involuntary admission under MHA includes that a person has mental illness, they are a danger to themselves or others, they are unable to take care of themselves due to their mental illness, and they refuse or are unable to consent for the treatment. What are the patient's rights under MHA even when there is involuntary admission? Includes right to information about their admission and treatment, right to appeal the admission, right to access legal aid, right for a second opinion, and right to live in the least restrictive environment. The MHA allows patients to make advanced directives when they are well, stating their wishes for treatment if they lose capacity in the future. This is a powerful way to uphold the autonomy. Our ethical duty is to ensure all legal requirements are met, to use the least restrictive means possible, and to continuously assess the need for involuntary treatment. This is the physician charter for professionalism. These guidelines were given in 2001, and it is stated in our CTP textbook. The fundamental principles include primacy of patient welfare, patient autonomy, and social justice. There are a set of commitments that includes professional competence, honesty with patients, patients' confidentiality, maintaining appropriate relationship with patients, improving quality of care, improving access to care, just distribution of the finite resources, scientific knowledge, uh, maintaining trust by managing conflict of interest and professional responsibilities. Coming to the critical analysis of guidelines in the Indian Psychiatry as per the MHA of 2017. Coming to what are the strengths of that the MHA provides us with, it gives us a rights-based approach. The most significant strength is the explicit recognition of the rights of persons with mental illness. This fundamentally reframes mental health care from a charity or control model to one of entitlement and dignity. It aligns strongly with the ethical principle of justice and respect. Example, the right to assess mental health care and the right to live with dignity are powerful statements that aim to correct historical injustices. It also gives us an emphasis on autonomy, that is, the introduction of advanced directives as per Section 5. It's a revolutionary step for patient autonomy in Indian mental health care. It allows individuals to express their treatment preferences when well, which must be respected even if they lose their capacity later. This directly upholds the principle of autonomy, ensuring a patient's voice is heard even in vulnerable states, and reduces the potential risk for paternalistic decision making. Prohibition of inhumane treatment, that is more non-maleficence. The explicit prohibition of cruel, inhumane, and degrading treatment, as per Section 26, includes strict rules on restraints and seclusion. It is a vital ethical safeguard. This directly assesses non-maleficence, aiming to eliminate practices that can cause harm and violate human dignity. Regulation of ECT. Stringent, stringent regulations around ECT, particularly the prohibitions for minors and the mandatory use of anesthesia and muscle relaxant, are crucial for patient safety. This demonstrates non-maleficence and patient protection. Focus on community living, as per Section 19, promotes recovery and reintegration, moving away from institutionalization. This aligns with beneficence, that is, promoting well-being and justice, ensuring access to least restrictive, more human environment. Non-discrimination, that is Section 3, explicitly prohibits discrimination on various grounds, including mental illness itself. This directly supports the principle of justice and aims to combat the pervasive stigma associated with the mental health condition. Coming to the challenges, implementation gaps between law versus reality. The biggest challenge for MHA 2017 is often its implementation on the ground. A strong law doesn't automatically translate into effective practice without adequate resources, infrastructure, and trained personnel. How effectively are the rights guaranteed by the MHA actually being realized for every person with mental illness across India, especially in remote or underserved areas? Coming to the capacity assessment, that is subjectivity and training. While the MHA mandates capacity assessment as per Section 4, the actual process can be subjective and challenging. There is a need for standardized practice tools and consent training for mental health professionals to ensure accurate and ethical assessments. The challenge for it is in a busy clinical settings, a thorough capacity assessment might be overlooked, leading to decisions that inadvertently undermine autonomy or impose unnecessary interventions. Nominated representative, practicalities and potential conflicts. The concept of nominated representative, as per Section 14, is ethically sound for upholding autonomy when capacity is lost. However, practical challenges include identification: who is the truly best representative of the patient, ensuring the representative genuinely cares in the patient's best interest rather than their own families. Many patients and families may not be aware of this provision. Involuntary admission or supported admission under Section 89, the ethical tension between autonomy and beneficence still remains. The challenge here is in the situation of acute crisis. The process of involuntary admission must be swift enough to prevent harm, yet robust enough to protect rights. Over resilience on involuntary admissions due to lack of community-based crisis services can still occur. Resource allocation, that is the justice gap. India faces a severe shortage of mental health professionals, beds, and facilities, particularly in rural areas. Persistent stigma, that is, while MHA aims to reduce stigma through its rights-based approach and non-discrimination clauses, deeply ingrained societal stigma and discrimination against mental illnesses are difficult to legislate away. The challenge here is that people may face social exclusion, discrimination in employment, or reluctance from families to seek care despite the legal protections. Ethical practice extends beyond the legal compliance to actively challenging stigma. Training and awareness. For the MHA to be truly effective, all stakeholders, mental health professionals, need comprehensive training and awareness about its provisions and intersection with other laws. MHA operates within a broader legal framework. Its interactions with other laws like criminal and family law can sometimes create complex ethical and legal dilemmas that require careful investigations. So basically, we conclude here that ethics is a journey. It's not a one-time test. We'll always be learning, thinking, and facing new ethical choices throughout our career. There are no easy answers to being ethically correct. Often we'll have to choose between two good options and two difficult ones. It's all about navigating the gray areas. What should we remember is always be aware of our own biases, values, and feelings. Follow our professional rules and guidelines. Always put the patient's well-being first. Where in doubt, ask for help. Talk to supervisors, colleagues, or hospitals ethics committee. We don't have to figure it out alone. These are all my references. Thank you.